Hi, Mike Gibson, Dr. Dan Atar, and we're coming to you live from ESC 2025, and we're talking about your trial randomizing patients to discontinuation of beta blockers in the setting of MI. Dan, what did you find?
So let me just say, by way of background, we have, if we look back 40 or 50 years, we have this incredible evidence base for post-infarction patients who had been randomized to beta blockers versus placebo. And one crown example is from our own Dr. Terje Pedersen, who performed the Timolol trial. And what he found was a 40% reduction in all-cause mortality when he followed the post-infarction patients just for 3 years. So that is, of course, a part of the entire evidence base that has coined even the guidelines, and there is a certain strength of recommendation to treat patients today with beta blockers when they have survived an infarction. Now, that said, we do not need to emphasize how much that has changed in infarction treatment. Basically, revascularization has changed the field completely, but also the entire diagnostication is different today with high sensitivity troponins, and not least the post-infarction secondary prevention has changed the landscape completely. So in this setting, we decided to embark on a randomized trial that would assess whether beta blockers still have a place in post-infarction patients.
Tell us a little bit about the design, how many patients, and when were the beta blockers discontinued, and what was the follow-up?
Right. So we decided on a probe design, prospective randomized open label, but with blinded endpoint evaluation. Our endpoints were basically taken out of the national registries, but also all endpoints were independently adjudicated by two independent cardiologists, by a committee. And we enrolled in total together in Norway and in Denmark. Together, we enrolled over 5,500 patients. The design was such that we should give the beta blocker no later than 14 days after the index event. But in reality, the randomization occurred already at date 2 in median. And our total follow-up time was 3.5 years. We had the advantage that we could blindedly monitor the event rate, so that we were sure that the power of the study would be sufficient to show an outcome. Because what could be discussed, what we discussed very much in the beginning, is it actually a non-inferiority trial or is it a superiority trial? And we decided at the end, let's give the beta blockers a chance to show their superiority. So that was our power calculation. 25 sites in Denmark, 19 sites in Norway. The incredibly lucky situation was that we shared our protocol. So the trials were basically identical, because Corona has slowed the inclusion as expected, and even the event rate was lower than what we anticipated. So it was very lucky that we had the opportunity to merge the trials. That was done in 2021. And again, basically identical protocols.
And what did you find?
So our primary endpoint was a combined endpoint of all-cause mortality, recurrent MI, urgent revasc, stroke, heart failure, or malignant ventricular arrhythmia. And those patients on beta blockers experienced that primary endpoint in 14.2% versus the other 16.3%. leading to a hazard ratio of 1.16 and a p of 0.03. So beta blockers in this study showed superiority against no beta blockers. And I must say, although all these elements of the combined endpoint went into the same direction, the endpoint was partly driven by reinfarctions occurring less in the beta blocker group.
Good. Well, so how does this affect our thinking right now? Controversial area. So, in 2025 and beyond, do we give beta blockers post-MI? What's your feeling?
Yeah, so I think the discussion is being inflamed again by this result because, interestingly, when we rolled out the study, most of my colleagues, when I traveled around to the hospitals and sold in the study design, most of the colleagues said it's really about time to dismiss beta blockers as post-infarction care. One aspect that we must keep in mind, in contrast to previous post-infarction beta blocker trials, we allowed an LVEF down to 40%. And that's, of course, a very interesting subgroup analysis. And as you have seen, there has been also a dedicated individual patient-driven meta-analysis in the same session that looked at the LVEF patient population from 40 to 49. But irrespective of that, I think the majority of the cardiovascular environment was quite ready to say, now we close that chapter and there is no need any longer for beta blocker treatment. And I think it's an interesting addition to the knowledge base that we now can say, well, we have shown at least a significant advantage.
Great. Well, Dan, I know how hard these trials are to do. Congratulations on 5,000 patients shedding light on this very important question. Thanks for joining us today.